blood loss compensation. A hemorrhage or bleeding is any types of escape of blood from the bloodstream into external surroundings, tissue of cavities of the body. Blood volume in males is about 5,200 milliliters, in the female about 4,000 milliliters. One of the case of death of the wounded people in a battlefield is acute blood loss and shock. During the Second World War, people who died of blood loss accounted for 30% of all those found at a battlefield, accounting some data up to 50%. 60% of those who died of blood loss in a battlefield had chest or abdominal wound. The number of those with limb wounds was number low. If a heavy bleeding occurs, there is not actually a single chance to save people in a battlefield. However, a turning quet can be applied on limb vessels. Therefore, the management of injuries of limb vessels is a great practical importance, as they account for 96% of large vessel wounds registered at the stages of medical evacuation. Among fatal hemorrhages, abdominal bleedings rank first. Chest, abdominal, and leg limb vessels account for up to 30% of bleedings. The frequency of blood vessel wounds is steadily rising in modern military conflicts, and according to different authors, it make up from 2 or 3% up to 5 to 8%. Moreover, limb artery injuries make up from 50 or 70 to 90% of military vessel traumas. The wounded patients with injuries of great vessel are referred to as a group of those who can be potentially saved. That is, people who can survive in a case timely and proper first aid has been provided to them. The share of deaths due to the war in Afghanistan made up not less than 10%, whereas military conflicts in the northern causes up to 25% deaths among the wounded in a battlefield. In 19% of them, the immediately cause of death was external bleeding caused by the damage of the great vessel of limbs. Postmodern examination of the wound wounded of the USA Defense Force, who were killed in a battlefield of the war in Iran and Afghanistan 2001 up to now showed that 18% of them died from bleedings. In total, hemorrhages from limb wounds account for the up to 10 or 15 of all deaths in a battlefield. Despite upgraded hospital care and develop of new homeostatic tools, the rate of the pre-hospital errors in the treatment of the great vessels of limb make up 30% and frequency of poor care cases 50%. The equipment of the first aid kits of military population with hemostatic agents has a result of in a significant advantage in management of the problems temporary pre-hospital hemostatics. Oversight manufactured offered a new form of their use with napkins, bandage cloths, sponges, and suspensions. In the last decade, in the number tourniquets made up of modern materials have also been developed. A new use of blood pressure cuff was inverted special balloons. For wounded occupation and pneumatic anti-shock devices from external compression were introduced. Classification of vessel injuries. Based of the appearance of the damaged vessel. Arterial, manifested of as a pulsing spurt of gross red blood, which escapes very quickly. Venous, dark red blood oozes out from the wound. Blood clots forming in the damaged vein may be washed away by the bloodstream. Therefore, a significant blood loss is likely to occur. Parenchymatoses observed when parenchymatoses organs, liver, pancreas, lung, and kidney, spongy bone, and erectile tissue have been injuries. In such cases, their whole surface starts to bleed. In pancreamatosis organs and erectile tissue, damaged vessels don't contract, do not move deeply into the tissue to be compressed by it. The bleedings may be very profuse and dangerous, as it is very difficult to stop them. Capillary surfaces, superficialis blood is similar on arterial blood in color, It looks like a bright red fluid. Blood leaks out in a small amounts and slowly. This is called blood dew. Blood appears and on the damaged surface slowly as a small, slowly increasing drop like drop of dew or considered water. Mixed arterial and venous. When vessels constitute one and the same vascular nerves bundle and are injurious simultaneously. It mostly happens when parenchymatous organ, liver and pancreas, lungs and kidneys, which have an external network of arterial and venous vessel, are injuries. It is also common to deep penetration injuries of the chest and abdominal. Based of the origin. According to the origin, hemorrhoids can be traumatic, caused by vascular damage, and atraumatic to their distraction induction by pathological process or increased permeability of a vessel wall. Traumatic. A traumatic bleeding occurs as a result of injuries, exposure of organs and tissue which exceed their stretch capacity. A traumatic hemorrhage is associated with acute damage of the vascular network structure at the site of injury caused by external factors. Pathological. A pathological bleeding results from pathophysiological process occurring in the patient's body. It can be caused by an impairment of any components of the cardiovascular and blood coagulation system. This type of bleedings develop in response to minimal provocative exposure or even without it. Based on the damage, complete transfer the rupturous vessel and diverge in complete rupture, lateral performance injury, and fragment does source the vessel. Tangential wound, no damage of the intima. The same thing occurs when something is hurt. No bleeding is present, but in a hole the wall disrupts with is followed by the hemorrhage. Based on the clinical presentation, without primary bleeding and hematoma pulsation, with the primary bleedings involving pulsation hematoma, blood leaks out of the rupturous vessel, draw aside the tissue and enters the peripheral, and of the vessel where a pulsation hematoma form. That is why to diagnose it, you have to auscultation the injured based on the escape of blood, external bleeding, internal bleeding within a typical of a cavity damage, tissue hemorrhage, typical of multiplate close fracture of pelvis bone, which results in impaired integrity of many vessel and blood. All this out into intermuscular spaces and joints. Tissue hemorrhage is arrested by vessel ligatation. If a vessel cannot be found, the field is transfused until the pressure is in a vessels and hematoma is equalized. Based on the time, primary hemorrhage, repeated hemorrhage when the rupture site is small and is occasionally slightly open. Secondary hemorrhage occurs after a whole early type within 5 days, late type after 10 days. Secondary bleedings mostly occur to the softening and suppuration of thrombi or gross abscess in the wound. Based on the severity, mild 10 or 15% of circulatory volume, up to 500 milliliter hematocrit over 30%. Moderate 16 to 20% of circulatory volume from 500 to 1000 milliliter. Hematocrit over 25%. Severe 21 to 30% of circulatory volume from 1 liter to 1.5 liter hematocrit under 30%. Massive more 30% of circulatory volume over 1.5 liter. Fatal more 50 or 60% of circulatory volume over 3,000 milliliters. Absolutely fatal more 60% of circulatory volume over 3,500 milliliters. Compensatory mechanism such factor as the says venosity of blood loss, the patient's age, general condition, and the condition of the cardiovascular system are circular for bleeding outcomes. There are 4 stages in the compensatory mechanism. First, vascular refractory. Second, hydremic stage. Third, medullary. Fourth, restorative stage. Vascular refractory stage The first stage develops on the second day after the injury. Bleeding results in a reduced circulatory volume, bleedings about hemovolemia, with stimulated is the sympathetic adrenal system. Adrenaline affects capacitance vessels, veins, and causes increase in the vascular wall tone. As a result, blood deposits, which are normally stored in veins, become including in the blood flow. In a temporary increase, the venous return to the heart, which results in a blood circulation normalization. Hydrodynamic stage, the circulatory volume increased as interstitial fluid becomes included in the blood flow and to the fault retention. For a person weighing 75 kilograms, the mobile volume in the interstitial volume amount to 20 liters. However, only half of its mobile, whereas in effect only 500 or 700 milliliters get into the circulatory bed. This fact accounts for the safety of blood donation. The mechanism of this stage is a neuroendocrine nature. Blood loss induced a dramatic decline in the circulatory volume, hypervolemia, extended volume receptors located in the carotid body and the aortic arch send signals to the posterior hypothalamus, where aldosterone stimulation factor, release factor, is synthesized. In is stimulated the production of aldosterone in the adrenal gland. The hormone causes sodium retention in the body due to its increased reabsorption in distal tubules of the kidneys. Increased content of sodium in the blood causes excitation of osmoreceptors. The signal is transmitted to the anterior hypothalamus, from which is passed to the pituitary gland. The secretion on antidiuretic hormones is stimulated with the caused water reabsorption in the kidneys. Medullary stage. Hypoxia included by a bleeding activity, the synthesis of erythropoietin of kidneys. Erythropoietin is activated young cells of erythroid lineage from and enter the peripheral blood. Now it's finish our время, our time. Давайте мы сейчас отключимся и сразу подключаемся, без перерыва. We haven't we must continue our lecture. Next clinical presentation of blood loss. Acute blood loss is associated with distinct symptoms. The patient of pale becomes sharp-featured, gets synchrony, asks for the drink. Their limbs are caught by the feel. Their pulse accelerate to 120 to 140 beats per minute, and in case of heavy blood loss, become 30, scarcely perceptible. Evening feeling of hurried breathing, shortness of breath, and decrease in arterial pressure are observed. In a more severe blood lossless, and the patient faints, their pupils dilate, muscular convulsation, and sometimes urinary incontinence develop. The cause of a blood loss underlies the selection of the therapeutic interventions. It should be kept in mind that a shock can develop a response to blood loss. Degrees: 1 shock. Compensated blood loss, normally with a volume of 5 to 10 milliliter kilogram. It's 500 or 7,500 milliliter. Apparent changes in hemodynamics may be absent. Degree 2 shock, subcompensated blood loss, normally with a volume 11 or 18 milliliter kilogram, about 1 liter, 1.5 liter. Systolic BP decreased to 90 or 100 milliliters Ag. Accelerated pulse 100-110 beats per minute. Scan pallor colors at peripheral veins. Degree 3 shock, uncompensated blood loss, normally with a volume of 90 to 30 milliliter kilograms. It's a 2 or 2.5 liters. Grave condition, systolic BP 60 or 80 milliliter Ag. Pulse accelerated to 120 beats per minute for pulse volume. Severe skin pallor called sweat. Degree for shock, decompensated blood loss, normally 35 milliliters. It's 2.5 or 3 liters. Extremely severity condition. Consciousness becomes confused and fades away. Systolic BP is lower than 60 milliliters Ag. Severe tachycardia up to 140, 130 beats per minute. Pulse can be felt only on large vessel. Laboratory signs of a blood loss. Change it in the red blood, decline in hemoglobin and hematocrit. Methods of the estimating blood loss. Empirical, the size of a clot weighing measured, the escapes blood and so on. Determining the Al-Gore-Bury shock index, 90, 70, 68, 67. Ratio of the pulse rate to the level of systolic arterial pressure. 0.8 blood loss volume 10%, 0.9 to 1.2 blood loss volume 20%, 1.3, 1.4 blood loss volume 30%, 1.5, 1.6 blood loss volume 40%. Using the Phillips and like method 1946, this method was developed by Phillips and Van Slyke. In publication, it's referred to as Phillips-Cooper's sulfate method. The method is simple, reliable, and quite rigorous. It involved the following procedure: is the original cuprum SO4, SO4 solution with a specific weight of 1,100 is prepared in advance. Then it's used to prepare a number of solutions with specific weights from 1015 to 1075, which can be stored for a long time. A drop of blood is added into a dropping pipettle, then withdrawn into vials with a solution until such a concentration is achieved that a drop starts hanging in the liquid. It neither things now gets to the surface. The specific weight of this solution is equal to the specific weights of blood. Associated blood loss according to the Barashkov method 1956 to estimate the Says of a blood loss in separate whales, a collection of cooperative surface solution with a relative density from 1.060 to 1.040 is repaired. The blood of the injured patient is gradually repaired into the wrist whales. The relative density of the studies blood will be the same as then that of the solution in which a drop is hanging. Neither gets to the surface, not sinks. Way of determining circulatory volume, analyzing nomograms, and using rheovasography and Evans blue dilution method and radionuclide method. Clinical observation. Clinical observation made is possible to establish a certain relationship between between the type of damage and blood loss volume. Clark, 1951, Belякov et al., 1980. For fracture blood loss are as follows. For shin bones fractures, the blood loss is 0.5, 1.0 liter. For closed femoral fractures from 1.5 to 2.5 liters. Chest injuries from 1.5 to 1.3 liters. 2.3 liters. For extensive pelvis fractures from 2 liters to 3 liters. Emergency management of hemorrhages. Measure at the site of the accident, arrest of bleeding. Method of arresting bleedings. Mechanical, physical, thermal, chemical, and biological. Temporary. Wound tamponade application of compression bandage, manual pressure, gauze tamponage, application of tourniquets or close tourniquet and maximal flexion of joints, clipical and wound, using a temporary vascular bypass, using biological tamponades, hemorrhagic and dilating sponges. Topical application of agents having adhesive properties, crossing the wound surface, causing vessel narrowing, and stimulation local clotting, and successfully use it to the arrest external bleeding. The most popular tools are gelating sponges, spondyostan, geliform, collagen coated plates, tissue flies, oxidized regeneration cellulose, cervicale, and the tachocomb agent comprisin, fibrin adventure glue. You should keep in mind that it's impossible to arrest the bleeding from damaged leg aerative and vessel using only the topical hemostatic tools listed above. They have to be complemented by other ways of arresting hemorrhages. However, today new generation contact hemostatic agents such as observers agents, Celox made trade Great Britain, quick load wound start are catching on. They have a great advantage over tourniquets or compressions bandage application as a practically and bleeding can be stopped in several seconds without any complication. In the SIS, the select contact hemostatic agent has been registered and become available for weight use. Now it is being registered in Russia. The agent has no contradiction. In Russia, a clinical trial involved a domestic agent with similar properties. Hemostop was completed failed months ago, and now it's also available for use. To use such agent, one has to sprinkle the required amount of the dirt into the amount of compress with a vial for 5 minutes. After that, you have to apply a compression bandage. Infusion therapy. The infusion of large molecular solutions is used in the case of degrees 1 or 2 shock for 400 to 800 milliliters of polyglycine or gelatinol. In the case of degrees 2 or 3 shock after the transfusion of 400 milliliters of polyglycine. It's necessary to transfuse 500 milliliters of Oleringer's solution or 5% glucose. The polyglycine infusion has to be resumed. Its a total share must not exceed 1.6 liter. Alongside with infusion, local anesthesia and 0.25 or 0.5% Novocaine has to be administered at the dose of 150 to 200 milliliter at the signs of fractures to the numb of a patient. Conditions and short anesthesia can also be used. In case of degree 3 or 4 shock, numbing can be administered only after the transfusion of 400 or 100 milliliter of polyglycines after the introduction of 300 or 400 milliliter of solutions. Through the immobilization of a fracture is indicated. Another indication is a single intravenous administration of 60 or 90 grams of prednisolone or 6 or 8 milligrams of dexamethasone. It's not recommended to attempt to quickly raise BP as high as possible. It's a contraindicated to infuse pressure amines, metazone, noradrenaline, and other, to so-called anti-shock fluid. It is also forbidden to introduce narcotic analgesics when an injury of inner organs or internal bleeding of suspected, as well as when the systolic blood pressure is lower than 60 millimeter Hg. It's not practical of administrated properly manageable long-active analgesics at the sites of the accident of during transportation. The same is true for neuroleptics and neuroleptic analgesics. Special quotation should be exercised when dealing with a patient with a psychomotoric agitation, as the later may be a result from hypoxia or brain injury. In halation anesthesia, nitrous oxide and oxygen into the ratio 2:1 methoxyfluorates can serve as a method of choice. Make sure to be taken during the patient transportation. In the fusion of polygon of gelatin must be continued. In the case of multiple injuries and degrees 3 or 4 shock, the patient has to be transported under nitrous gas oxygen anesthesia. When breathing difficulty is noticeable, trachea intubation and artificial lung ventilation and indicated. If the intubation is impossible, respiratory assistance is provided using as a breathing mask. If the patient is in a very poor condition, and the long transport is expected, you don't have to be in a hurry. Primarily, it's advisable to compensative blood loss at least partially anesthesize the patient, immobilize when safety, and so on. However, if an internal bleeding is suspected, the patient should be hospitalized as soon as possible. In patient measure, one of the major measures into the antimatter shock, the bleedings. Involved vessel ligation, thickness, hand ligation, and after exciting the wound, twisting a vessel, crushing a vessel, vessel suture, vessel prosterness, and bypass, electrocoagulation, and the use of a laser scalpel. If a vessel is suturing is impossible, won't transport need in used. Vessel embolization. This method involved the introduction of an air bubbles into the vessel, which is fixed on the vascular wall pressure valley and at the site of injury. It is mostly used in blood vessel surgeries. Compensatory of circulatory volume alongside with the infusion of a circulatory solution is performed by means of a hemotransfusion in the case of degree 2 or 3 shock compensation not less than 75% blood loss. In case of a degree 4 shock, up to 100% of more or more. After the transfusion of each 500 milliliter, 10 milliliter of 10% calcaneum gluconate is administered. If hypotonia of each 500 milliliter, if hypotonia and a long-term decreased over 30 minutes in systolic pressure under 70 or 80 milliliter Ag, pressed intraarterial infusion and introduction of 90 to 180 milligram of prednisolone are indicated. The administration of pressor amines in contraindicated. Blood transfusion have been alternative with the introduction of 5% glucose and rengenous solution at a dose of to 2500 or 500 milliliters. After systolic BP is stabilized at the level under 100 milliliter Ag, intramuscular administration of the mixture of polyglucine or 5% glucose and 0.25% novocaine in equal proportion is indicated as long as a BP pulse per hour urine output and skin color are monitored. Up to 500 or 1000 in the first 24 hours to eliminate metabolic acidosis after the compensation of the circulatory volume. 200 or 600 milliliter of 4% sodium hydrocarbonate is administered. In the first 24 hours, intravenous administration of 6 or 12 grams of potassium chloride is indicated. Potassium should be introduced with with 20% glucose and insulin at the rate of 1.5 gram of potassium per 200 milliliter of the solutions, and 1 hour of insulin per 2 gram of dry glucose. It's also recommended to administer B group vitamins and ascorbinic acid. Normally staging from the second 24 hours heparins and sometimes fibrinolysin at additioned, 60% of the injuries patients with have indication for transfusion of blood or its components. It's a hospital setting on the first 10 or 12 days. The 2 months treatment of the patient with traumatic injuries registered point or 1.5 liter of blood, and its components: red blood cells 1 liter, plasma 0.33 liter, albumin 0.1 liter, fibrinogen 1 grams, protein 0.25 liter. Bubble blood supply service in the Russian military force. Blood is a banks of a massive scale. This is colored out by the Institute for Blood Transfusion and the blood transfusion station, which are located in the region. According to some hospital data, the first blood transfusion in the Russian army was performed by Dr. Golovin at the war time, and its outcome were favorable. The pioneer of a blood transfusion in the Soviet army was Professor Shamov, who did a blood group-based transfusion in the Military Medical Academy in 1990. The Shamov and Lansky developed a serum for determining blood groups. Blood supply service included planning of demand blood, record keeping and supply of field and health facilities, dispensing and storage of blanket blood. The problems of blood transport transfusion at the stages of medical evacuation are kept under the several lanes of a blood supply service. At the stages evacuation, at the first stage, blood transfusion are given to 2 or 3% of the wounded for light support. At the second stage, transfusions are received by 10% of the wounded in the specialized institutes and hospitals, 5 or 8%. At the first stage, no more than 240 milliliters of the blood transfusion. At the second, 500 milliliters. Some cases several times. There is a Birkett formula to calculate the demand for blood at the stages of a medical evacuation. Blood is supplemented by the Department of Blood Transfusion within the principal medical establishment. Similar department will think battlefield and army institution. Blood transfusion station. Blood can be delivered by planes, trains, vehicles. Blood is stored in basements at a temperature +4 or +6 C. In summer, it can be storage in a well shaft. Storage plants must be equipped with a stent for blood which sedimented, for blood which has sedimented. There must be 3 layers of plasma at the top, layers of leukocytes and large layers of erythrocytes. Double full blood and the blood unstable for blood transfusions. The shaft life blood and is 15 days in a battlefield setting, whereas in a time is a pace up to 20 days or more. In the bridge medical compensate BMC and separate medical determination CMD, they start by transfusion group 1 blood, perform blood compatibility test and biological test. 20 milliliters are transfused. The patient condition is monitored. In the hospital, they give a blood transfusion base of blood groups. One groups 60%, 2 groups 25%, 3 groups 15%. It's required check is H factor compatibility. In a BMC at SMG, blood transfusion given a patient with wounded limbs. It's dangerous of transfuse blood in the case of internal bleeding. The main blood transfusion is performed in an operating room during abdominal, chest, or limb surgeries. Thank you for the attention. It's a finish. Thank you. Bye.